Welcome to Virtual Unit Peer Leader Annual Training developed in consultation with earlymobility.com. In this training module, we will be covering what it means to be a unit peer leader. This is one in a series of 7 training modules which are now available to you to assist with your unit peer leader training. A disclaimer, earlymobility.com does not endorse any vendor or any product and does not sell any safe patient handling and mobility technology. The videos used for these modules are purely representative of the types of safe patient handling and mobility assistive technologies that are available on the market, and there are many versions of every assistive technology that you will see in the videos. Check with your Safe Patient Handling and Mobility Facility Program Manager to determine the models that you have in your facility. This training module, like we said, is on what it means to be a unit peer leader. Welcome to the amazing role of helping keep your colleagues, your co-workers, and your patients safe. Thank you for stepping up to this role. Whether you are here because you volunteered or because you were told to be a unit peer leader, we are so glad that you are here. Your willingness to be a unit peer leader is testimony to your caring heart for your patients and your fellow caregivers. Join us on our mission to provide the safest care possible in our facility by being the best unit peer leader you can be. You are the glue that makes the mission possible. We can have a great policy, but we cannot get the outcomes without you. Your safety officer relies on you to help your unit team be safe for themselves and for their patients. You help your co-workers how to screen their patients and use the right safe patient handling and mobility tools. You are the one implementing the program on your unit for your co-workers, yourself, and your patients. Building the program without you is like throwing a bunch of ingredients in a bowl without cooking them and expecting a cake. You are like the heat that makes all the ingredients come together for that delicious cake. Own your zone and don't be afraid. Great leadership supports the program, but you are the one that helps it run smoothly on your unit. Great education is pivotal to the success of the mission, but you will be the one to help make that educate stick and to make sure all your team members on your unit understand what they need to do for safe patient handling and mobility. Now, this may seem a little overwhelming, but you are not alone. We want you to understand how valuable you are and how much you are contributing to the mission of safety for your co-workers, your patients, and yourself. The training modules that are included in this bundle will help you and your team provide care that is safe for all your co-workers and for the veterans they strive to care for. This is our mission. You are vital to the success of the mission. We have a message here from your National Safe Patient Handling and Program Manager, Dr. Tony Hilton.
Hello, my fellow unit peer leaders. Welcome to this training that we've prepared specially for you so that you can have the skill sets you need to be able to function successfully in your role as a unit peer leader for safe patient handling and mobility. We welcome you to our safe patient handling family. We know that as we work together, we can certainly conquer a lot of the problems we face day to day as a team. You're going to be learning a lot of wonderful information about how to function in the role, the skills that you need to teach your partners on your units, your patients, and your colleagues. We want you to enjoy this experience and take it back to your units and live the life of being safe. Safe when handling your patients, safe for our patients, and safe for everyone. Thank you so very much for being part of this unit peer leader training, and go have fun. Thank you.
So unit peer leaders, you have a very important role under Safe Patient Handling Mobility National Directive number 1611. SPHM Directive 1611 has required programs in all VAs since 2010. The program requires that every facility, every unit has unit peer leaders, recognizing that they are critical for a successful program. SPHM programs include unit or service peer leaders on all shifts, all areas where patient handling occurs, who provide training, coaching, and assistance to frontline staff. And we offer unit peer leader training at least annually. Why do we need peer leaders? Because peers have more credibility. You know the work that you and your peers do every day. You have a better understanding of concerns and pressures on your unit. You can be effective role models. And you can learn lifelong skills and teach them to your other unit peer leaders and to your co-workers on your unit. When we think about leadership, a good objective of leadership is to help those who are doing poorly to do well, and to help those who are doing well do even better. So no matter where your co-workers are on the spectrum, if they're just new to safe patient handling or to their role on the unit, or if they're a seasoned practitioner, we can all improve. So be a UPL, believe in the program, motivate your co-workers. Use your knowledge to empower your co-workers to be successful. Inspire your team and lead by example, providing care that is safe for caregivers and veterans alike. What does a peer leader do? You provide expertise in the safe patient handling and moving of patients and residents to the unit team. Your expertise is needed to help train and advise co-workers, demonstrate equipment use, champion the Safe Patient Handling and Mobility Initiative on your unit, on the day-to-day workflow. But you're not alone. You have a whole team that you have joined and who are here to support you in being successful in this mission. You have other peer leaders on your own unit. You have your unit-based nurse educators, your facility coordinator or program manager, your unit manager, your VISN point of contact, and other VISN facility coordinators or unit peer leader contacts. We have national conferences, regional conferences. Reach out and network with those around you. That will help you be successful in your role, and you can then also help others be successful in theirs. It truly does take a village. Now, this slide is a complex slide that shows all the areas that safe patient handling and mobility touches. You don't have to be responsible for all these areas, but this is one of the areas where you have a team of people. Get to know the people who are in these departments. And if you don't know them, reach out to your facility coordinator, program manager, your other peer leaders to help you understand and know which people to contact when you have certain challenges related to your program. Why is your role so important? And we use some cartoons here, right? Beats me why they don't allow this anymore. And you see two nurses lifting a patient manually. The second one, lifting equipment, who needs it? We'll just move the patient. Or the last one, wow, Crystal, was that cracking sound your back? Some of you may be able to relate to these pictures more than you might admit to. The underlying importance of your role is that manual handling is dangerous. It hurts us, it hurts you, your co-workers, it hurts your patients, and we want to make a change. Lifting and moving patients manually can cause career-ending and lifelong injuries to nurses and therapists every single day. We know that safe patient handling mobility programs work. Since 2009, the Safe Patient Handling Mobility Program just in the VA has reduced caregiver injuries by 45%. That's almost half the number of people getting hurt as were getting hurt before the program. Strong unit peer leaders, you are the difference between programs that really do prevent injuries and those that really are on paper and processes, but where caregivers continue to injure themselves while caring for their patients. The difference you make is tremendous. Evidence leads the way to change. As a unit peer leader, you make a difference every day on your facility and in your unit. You can work together to impact safety and injury prevention, early mobility, falls. You can help patients of size or bariatric patients move with dignity and comfort and ethically more dignified ways of moving. And you can help with all of the equipment. And as we see in the pictures, we've come a long way since these days of nursing. But let's make sure that our unit demonstrates that we have truly come a long way. We know manual lifting is dangerous. There are multiple studies that have been done, and these pictures and videos are used with appreciation and permission from Dr. Will Maris at the Biodynamics Laboratory at Ohio State University. When we look at the compression forces through our spines, you'll see the safe limit of forces, and you'll see the forces with manual activities with one person in red and manual activities with two people in green. Both of these exceed the safe limit of what our tissues in our backs can tolerate. Even with two people, lifting can cause injuries. And you'll see here the spinal compression as a function of transfer technique. When one person does a hug or a hook and toss, the load forces almost exceed maximal tolerance. But even with two people, the left-sided person, the right-sided person were both measured with those mechanical instruments. Both of them exceeded the safe limits. And you'll see the size of this person is not very big. When you think about some of our larger and heavier and more dependent patients, these forces are even more. So there's a video here that we're going to share with you from Dr. Maris that shares a little bit more insight. So you as a unit peer leader can have a good understanding of exactly what's going on, why manual handling is not good, and why we really need to be diligent about changing our practice to use mechanical devices. Let's listen to Dr. Bill Maris.
How many people here have had back pain? Maybe the way I should ask this is, anybody here not had back pain? Low back disorders are the most disabling condition known to mankind, not only in the United States, but around the world. You know, no matter what country you go to, you're going to find this is the #1 condition that puts people on the sidelines. So in the United States alone, we lose about 100 million lost workdays per year to low back pain. And we spend in the neighborhood of $100 billion treating people for low back pain. So, we're typically concerned about the disc. If you look at the spine, you have 24 vertebrae, and in between each one of these vertebrae is a little disc, which is sort of like a shock absorber. And if we look at this in close-up, we can see that there's good space in between those vertebral bodies that is offered by the disc. And we also see that you have these little tubes or cables that come out of the spinal cord, and these go down to serve different parts of your body. And if you put pressure on that, that's when you have a problem, sort of like you see at the bottom right here. So as a matter of fact, here's somebody who had a rupture of the disc. It's pushing against that nerve root, and that's when you get things like sciatica going down your leg. So how does this all occur? In order to understand how this occurs, we have to understand something about the anatomy of the disc and how it gets its nutrition. If you look at the disc, it's almost like a tire that you lay on its side. Okay, so it's got lots of crosshatch fibers, which are like plies of that tire, and in the center you got a gelatinous core, and it also has this tiny cap on the top called an end plate. That end plate is only about 1 millimeter thick, and its purpose in life is to diffuse nutrients into that disc. The disc itself has no blood supply like most parts of your body. So how does it get its nutrition? Well, it gets them from the vertebrae above and below, and basically what happens is these nutrients go through that end plate and nourish those fibers and make the disc happy. Now, we also get vertebral end plates. How many people here have had a vertebral end plate microfracture? Okay. How many people here have ever lifted anything heavy? Okay, you probably had a vertebral end plate microfracture, but you just don't know it because we don't have any nerve sensors or what we call nociceptors in that part of the body. It's okay if you get one of those, it'll heal. But what if your job requires you to get lots of these things? Well, these things will heal, but they heal in the form of scar tissue. And one of the things we know about scar tissue is it's thicker and denser than most other types of tissues in the body. So what do you think happens to those nutrients when they try and pass through this end plate? Well, some of them make it through, some of them don't. And subsequently we get atrophy of the disc fibers, parts of the disc die off. That's how we get weak discs, and that's how things get bad in terms of ruptures. So as an engineer, what we do is look at the load imposed on those tissues of the body compared to the tolerance. And so here's typically the way to look at things. Here's the tolerance of a tissue. Here's the load of a tissue. And if the load exceeds that tolerance, then you're going to feel pain. So what we try and do is design jobs so those loads are well below there. Now, here's the way we analyze this in the laboratory. See in the little window there, you see somebody doing a physical task, and we have markers on his body. We have electrodes on his body to look at muscle activities. You see the little contrails of the motion. We could precisely understand what somebody does. And this accuracy is tremendously accurate. It's down to about a third of a millimeter of accuracy. So what we do with that information is we build a physical model or a computer model of this person. And these things are proportioned relative to the size, shape, proportions of the individual. And you can see there we have the forces going in and out of the hands. We have the muscles that we're getting from the electromyography. We have motion. And then we could do something with these models that you can never do in real life, which is you could look inside there and measure exactly what's going on. So every one of these little red arrows is basically a vector of force that is being imposed on the disc. And you can see these things are straight back when this guy starts to pull, and then you see him swing to the side. That's because he's taking a step with one of his legs. So it shows how incredibly accurate we can get with these. As a matter of fact, we also do this for patients. So here's a patient. This is a patient's particular spine in the model with all the wear and tear and degeneration. And you can see we see muscles, which are the red arrows, bone cortex, which are blue. The green that you'll see here in a minute are going to be ligament forces. And you see the discs actually deforming, changing colors. So we can tell what the stress is there. So what do we do with this information? Well, we use it to interpret what happens when people are exposed to various risk factors. There are things you do have some control over. For example, here's a little study we did looking at BMI, body mass index, or how obese a person is. And the 0 here is if you're of the ideal level, which are the green bars. And the blue shows what happens if your BMI is increased by 5. The red shows what happens if increased by 10. And you can see these are nonlinear jumps. The jump from the green to the blue is moderate. The jump from the blue to the red are excessive. And so it's a nonlinear hazard to put on more body weight in terms of your spine. We also know that your previous experiences, like if you've had low back pain, could influence things. Loads are from 30 to 70% more when you've had low back pain before and you're doing a task. We've known since the days of Isaac Newton that force is equal to mass times acceleration, but we totally don't pay attention to that. So this is one of the things we've been trying to include in our studies at the Spine Research Institute. So if you look at the guy on the left, this is somebody who does not have back pain. And you look at the guy on the right, this is somebody who does have back pain. What do you notice? They move very, very differently. They're moving to about the same range of motion, but the way they get there is drastically different. Why does this occur? Well, we've done a little modeling here. We have both of these cases modeled. And what you see here are a bunch of white lines around the torso, which are the lines of actions of the muscles. You're going to see blue arrows coming up, which show the muscle activity, how much force is generated by those muscles. And then you're going to see the spine either stay green or turn yellow or turn red. The brighter the color, if it's red, that means you've got damaging forces occurring on the spine. If it's green, they're pretty minimal. So let's look at the asymptomatic person, the healthy person. And what you see is they're using their back muscles here primarily, and everything stays green as you bend over a lot, maybe a little bit yellow. And now compare it to what happens to the guy on the left here. Look at how large those muscle activities are, and look how he's using all those muscles around his torso. So what's happening here is you have what we call a lot of coactivity. So not only are the back muscles engaging, but he's got this tug of war going on between all the muscles of the torso, which are turning the spine red, because all of a sudden you're activating these pain-sensitive tissues we talked about. A very risky occupation is patient handling. As a matter of fact, of all the jobs in America, this is the most risky occupation, more than construction, mining, truck driving. An ounce of prevention is worth a pound of cure, whatever that means. But we know if you just invest a little bit of money into doing the proper things in terms of ergonomics, like using the right workplace setup, using the right understanding the risk factors and doing something about them, you can avoid 10, 20, 30, 40, 50 times that cost in terms of trying to treat people. Because the one thing we know is it's really, really hard to treat people for back injuries once they occur, especially if they involve the more serious injuries to the disc. The biggest factor in determining how to prevent injuries in the workplace is really all about recognizing where the risk is. It's not really that last effort that you put forth that caused the injury. It may have been the previous 1,000 times you did that led up to that final event. The prevailing attitude in a lot of industry is, well, I'll just work my way through it and I'm strong enough where it won't hurt me. But that's because you can't feel it. If you look at the construction of the disc, you have very few nerve endings in the disc that let you perceive the pain. And so when you're doing damage, you don't know it. And then once you do enough damage where the disc starts to bulge or starts to rupture, and you push against other tissues that are surrounding that, then you feel it. And that's why it feels to you like it happened all of a sudden, when it's really that was the straw that broke the camel's back. And if you understand when you're doing damage, when you're doing that work, then you can do something about it. We're taking the science, which we realize that the people who are actually going to use this information may not understand what we did or why we did it, and they really don't have to. But if we can present it in a way that shows them, here's how you apply it, that's when you get the win. Because they're the boots on the ground. Those are the people who are really out there saving people from back injuries every day.
So just a little bit of information that gives you the why and a little more understanding of what is going on in our backs. And those models, computer generated models, are amazing in helping us visualize what's going on every single time we manually boost, reposition, turn a patient. And if you heard from what Dr. Maris said, the time you feel the pain, it may not be just that time that caused it. It's the hundreds and thousands of times that you did that task before. And that's why prevention is so very important, and how you can understand the value that you are bringing to your coworkers by preventing those injuries. They may not feel it until 3-4 years from now. But if you can stop the manual lifting and boosting and repositioning now and offer a better way, you're going to help them. You have access to this video. Share this video with those who don't think they need to use equipment. Your work makes a difference. By championing the program, you are going to help reduce injuries. You will help your facility be an employer of choice, improve job satisfaction, decrease staff turnover rates, decrease musculoskeletal discomfort and injuries, foster a sense of professionalism and empower clinical staff. And you will also help reduce costs to your facilities. Workman's comp and employee injuries, back injuries, shoulder injuries, neck injuries, they don't just cost you, your coworker, yourself, they cost the hospital, the facility money. You're going to improve the quality of care, improve your patient comfort, security, and dignity. You will help them feel safer during transfers and mobilization. You will promote patient mobility and independence. You can enhance their ability to toilet. You can enhance their outcomes. You can increase their continence. You can decrease patient falls, skin tears, pressure ulcers, abrasions. You can help facilitate a proactive approach in perpetuating a culture of safety amongst your patients and your co-workers. And you can help with early mobility implementation, because we know that successful early mobility must be built on a foundation of safe patient handling. These are all the benefits that your work are bringing to your co-workers in your facility. Your work improves the patient experience. Dignity, we've talked about it. It decreases the fear of falling in your patients. It decreases the risk of complications like blood clots and pneumonia. It improves comfort and it empowers people to succeed. Who? You. You are the glue that holds the whole puzzle together. You need to know your unit managers, your unit-based educators, know which new staff needs skill validation. This includes intermittent staff who may not be familiar with your equipment. If you see a new face on your unit, introduce yourself. They might be new, you might not have met them yet. They may have to be checked off with their competence on all the equipment on your unit. Or they might just be floating to your unit for a day, for a week, a shift. Either way, if you see a new face, reach out and introduce yourself and know who to contact when there are equipment issues. Safe patient handling mobility equipment must get high priority in the work orders. Know who can place those and how to make that happen. So we've said this before, but make sure that you know all of the equipment on your unit, how it works, what the weight limits are, where the slings are. Know the skills checklist or competencies that are used by your facility and where to find them. Know the processes to ensure equipment is working properly and that your slings are available and accessible, and help train the staff on your unit. Training on your unit, all staff should be competent in all the equipment that you use. Coordinate patient fall simulations with your educator or your manager. Simulate the different things that can go wrong so that you can prevent them from going wrong. Know how to use the equipment for floor recovery. especially in emergency or tight spaces. You can assist other safe patient handling mobility unit peer leaders on their unit, or they can assist you on yours. Network with your team. Don't try to go this alone. Have opportunities that are available to you include skill fairs. You can help organize the safe patient handling mobility element of the skills. Discuss the need and the schedule with your educator and your manager. Meet with staff one-on-one to train them. Talk about safety at reports, huddles, staff meetings, shift handoff. Add information and input to virtual staff meetings and manager emails. Post safety information on your unit. Develop staff communication, unit-specific safe patient handling and mobility email groups, newsletters, unit binders. These may already be available, but if they're not, you can work with your facility coordinator, program manager to create them or update them on your unit. We provided some useful resources for you here in your PowerPoint presentation. So reach out and get the help. Use the resources that are available to you. You impact the future generations. The person who plants and nurtures the seed may never know the impact of their actions on those who come after them. Your work today helps countless people, not just today, but tomorrow and for years to come. Congratulations, you've successfully completed the module on what it means to be a unit peer leader. We hope you fully understand how valuable you are to our team. And we hope that you realize the difference that you make to your coworkers, to your veterans, to their veterans' families, and to your facility every day. Thank you for your service and your help giving back to those who have served.